at the ART centers. And the speaker is Dr. S. Anuradha ma'am. Dr. S. Anuradha ma'am is the Director, Professor of Medicine at Maulana Azad Medical College, New Delhi. She is also the Nodal Officer of the ART Center and the Program Director of the Center of Excellence in HIV at Maulana Azad Medical College, New Delhi. She has done her master's in infectious diseases from the London School of Hygiene and Tropical Medicine, University of London. She is the recipient of Postgraduate Fellowship in HIV Medicine, UCLA. She is also the member of the Technical Resource Group, ART and R&D, National AIDS Control Organization, Ministry of Health and Family Welfare. We welcome you, ma'am, for today's session and request you to start the session.
Thank you, Shweta. Good afternoon, everybody. I hope I'm audible. So what we are going to talk about today is we are going to talk about the integration of non-communicable disease, that is NCD screening, and the management of NCD among PLHIV at our ART centers. The session will go like this. We will just talk briefly about the prevalence of non-communicable diseases in HIV-infected people. Then we will talk about some common NCDs like hypertension, diabetes, mellitus, CAD, stroke, and talk a little bit about what is their pathogenesis. We will discuss about the screening and the assessment for non-communicable diseases in PLHIVs. And we will see how we can integrate the care of NCDs with the National AIDS Control Program so that the patients get a holistic care. We will talk about how to implement this integration because it is not yet fully implemented in all our ART centers. Some centers are doing it. We will see how we can implement this and how to proceed further and what are some of the challenges that we are likely to face along the course. So this is going to be the brief outline of this session. So we're going to run a pre-test. Shweta?
Yes, ma'am. Kiran sir, can we quickly run the pre-test? Thank you. The pre-test questions are now visible on your screen. All the participants are requested to please attempt the pre-test. Scroll through your screen. There are 3 questions in all. Please click on the correct answers. I'll read out the questions. Which of the following is not a risk factor for cardiovascular diseases in PLHIV? You have to mark all that applies. First is smokeless tobacco chewing. Second is total cholesterol less than 200. Body mass index, which is equal to 22.8 kilogram. Aging process and triglycerides more than 150 mg. Which of the following is not a criteria for diagnosing diabetes in PLHIV? The options are symptoms of diabetes or random plasma glucose is more than or equal to 180 mg. Fasting plasma glucose is more than or equal to 126 mg. 2 hour post 75 gram glucose more than or equal to 200 mg. Glycated hemoglobin more than or equal to 6.5%. Third question. Which of the following is or are the warning signs indicating presence of a mental health condition in children and adolescents? The options are weight gain, changes in academic performance, self-harm, and changing in eating habits. Please choose the answer of your choice. We have another minute for the pre-test, requesting all the participants to attempt the pre-test poll. Only 20% participants have attempted it till now. Thank you, everyone. Kiran sir, we can end the poll now. Ma'am, over to you.
All right. So let us talk about the concept of non-communicable diseases, NCDs, and I will be using the term NCDs from now on among PLHIV. All of us know that widespread access to ART has actually transformed HIV from a life-threatening condition to a chronic, manageable chronic condition. So this is something that we are all seeing. Our patients are living much longer. But because our patients are living longer, the demographics of the patients who are coming into the ART center or who are registered and visiting the ART center is now changing. All of us are now noticing that there is a significant proportion of PLHIV who are more than 50 years of age. That is, we are having a very significant proportion of our registered clients are now aged PLHIV. And so since these patients are now aging, the health challenges faced by these PLHIV due to aging, and because of that, they are more likely to develop NCDs not only because of the aging process, but also by which is compounded by the HIV infection itself. And now, non-communicable diseases or NCDs are one of the leading causes of non-AIDS related morbidity and mortality. In fact, we now know that the OIs and infections have reduced significantly since we have started a universal accessible ART to everybody. But now most of our patients are now suffering from NCDs. So detection and the timely management of NCDs in PLHIV is very critical to improve their quality of life. So this is a table which is taken from our guideline, and it will tell you about what are some of the non-communicable diseases that are prevalent in this population, and you can divide them into system-wise and organ system-wise. So you have cardiovascular system, in which you have hypertension, ischemic heart diseases or CAD, strokes. Then patients sometimes very rarely can have rheumatic heart. In respiratory system, you have the entire gamut of respiratory conditions like chronic obstructive pulmonary disease, occupational lung disease, asthma, restrictive lung disease. And among endocrine causes, one of the most important causes would be diabetes, and many of our patients are diabetic. Chronic renal disease and nephropathy is also emerging as a very important NCD. While we are very aware and we are looking for these organ system specific NCDs, what is less evaluated are some of these NCDs, especially psychiatric NCDs and psychiatric problems like depression, anxiety, schizophrenia, and other psychiatric illnesses. Anemia, hemoglobinopathies, some of them could be nutritional. Some patients among PLHIV also develop different kinds of cancers. They could be AIDS-related cancers or non-AIDS related cancers. And there's a whole list of cancers that develop in these patients. And patients can also develop conditions like arthritis, which can also be related to aging. So if you look at the NCDs that can happen in these patients, there is a whole list or a whole gamut of conditions that can happen in these patients, especially because they are aging and also because premature aging sets in the PLHIV. So if you look at the overall incidence and prevalence of the NCDs within the general population in India, and so this is a projection for metabolic age disease prevalence in the country, the overall prevalence for diabetes is 11%, pre-diabetes another 15%, hypertension in that subgroup was 35%, obesity, dyslipidemia, and if you see, all of these NCDs are much more frequent in the urban than in the rural areas, and projections in millions are for so many million people being affected with NCDs. If you look at disease-specific NCDs, let us talk about the cardiovascular diseases or the cardiovascular diseases. Cardiovascular diseases, as we know, is the most important or the number one cause of death worldwide among all people in this world. So the commonest cause of death in people is cardiovascular diseases. 1 out of the 3 deaths, in fact, are directly related to cardiovascular diseases. And over 3 out of 4 deaths from cardiovascular disease actually occur in the low and middle income countries. And that is something which we need to keep in mind. Low and middle income countries are facing an increasing burden of cardiovascular diseases. And the important cardiovascular diseases, of course, are CAD or coronary heart disease, also called ischemic heart disease. Some people call it CAD. Cerebrovascular diseases and strokes are also a very important manifestation of this vascular disease. They can also have peripheral arterial disease, especially if they are diabetics also. They can have very severe peripheral arterial disease, and some patients can actually develop finger gangrene and other gangrene of the foot and foot ulcers. And sometimes there can be other problems as well as rheumatic heart disease and DVT. But it is very important to remember that CAD and stroke are the two very important causes of morbidity, and both of them are also responsible for significant mortality. Why is there this slight increase in cardiovascular disease which is happening in India? The reason for that is, of course, there is a biological risk, and this biological risk is inherited because of genetic differences and also early life influences. But what is also important is that there are very important population level changes that are happening in our population at large. And the six major transitions which are responsible for these are epidemiological transitions, demographic transitions. Our population is now aging slowly. The number of aging people is increasing. There are multiple environmental effects to this aging process. There are socio-cultural changes that are happening. Our diets are changing. The way we work and walk and the amount of exercise we put in, what is we are doing is changing. Our economic profile is changing. So because of all these conditions or all these transitions, there is a very complex interplay between these population level changes and the biological risk which exists in Indians as a result of multiple genetic factors. And the complex interplay between these two conditions is actually giving rise to an increased cardiovascular disease epidemic among Indians. So let us look at some of the important risk factors for the development of cardiovascular disease or CVD risk in the world. The two most important ones are diabetes mellitus and hypertension. And you will find that in the few next slides also that you will see, when I talk about diabetes, I will talk about CAD. When I talk about hypertension, I will again talk about CAD. And these three, diabetes, hypertension, and dyslipidemia, have a very significant interplay leading to a very high risk of cardiovascular disease. Another very important factor is obesity, and it is important to remember that anybody with a BMI of more than 25 kg per meter square is taken as obese for the Indian population. These are the cutoffs for India. So when we saw the HIV epidemic initially, we saw that many of our patients were actually undernourished and were having very severe undernutrition. But now if you look at the patient profile who is coming to the ART centers, and if you check their BMIs, you will find that a very significant lot of them are actually having increased BMIs. And this is especially happening when a lot of people are now on DTG-based regimens, which is giving rise to weight gain. So this weight gain is contributing to obesity along with dyslipidemia, which is manifested as such and also is compounded by taking antiretroviral drugs. And all of these are putting our patients at very high risk for CVD. Another important anthropometric parameter to always consider is waist circumference. Any waist circumference more than 94 centimeters in men and 80 centimeters in women is significantly associated with increased risk of metabolic complications, and the risk increases much more when the waist circumference becomes more than 102 centimeters in men and more than 88 centimeters in women. And this is something that we are not actually measuring in our ART centers. So if we start doing this, we are not even doing this properly. If we measure the BMI and if we measure the waist circumference, we will get a very fair idea of what is their risk for cardiovascular disease. Physical inactivity, of course, many of us have become physically inactive by using our own cars, our own means of transport. We walk less, and there are many other reasons for that. Tobacco use, excessive alcohol consumption, both of them are very prevalent among the general population as well as among our PLHIV. Of course, unbalanced, unhealthy diets, high fat, high salt, and poor nutrition as such can also contribute to it. And there is always a very important family history of both diabetes, hypertension, dyslipidemia, as well as cardiovascular disease that contributes to increased risk for CVD in our patients. So when we do a screening, this is what is called the concept of opportunistic screening. Opportunistic screening means the patient has come to you for whatever reason. So our patients are following up with us every month. All we need to do is to screen them at this point of time. What we can do if you screen them is we are able to detect disease early if they have disease. If they have disease, then we can start early management, which includes lifestyle changes, other non-pharmacological changes, and if required, we can start pharmacological therapy early. By doing both these, we are able to prevent the comorbidities that can develop in these patients. Because diabetes, if you know, has comorbidities of renal disease, hypertension, stroke, all these things can happen in these patients. And we can improve the health and well-being of patients overall. And so that is what is the concept of opportunistic screening means. We are screening actively for these NCDs in our population. The National Technical Guidelines very clearly mentions that the overall aim is early identification of NCDs among PLHIV, thereby reducing their morbidity because of these and overall mortality because of NCDs. And it is very important that we are able to provide integrated and comprehensive management of both HIV and NCDs in routine program settings, which means our patients are managed for both the NCD as well as HIV within the same complex. So patients don't have to go to 10 places for their management. And that is what is meaning of integration of both these services. And we'll talk about that in the subsequent slides. So what do you do when patients come to you? You have to have a history taking and then we'll have to assess them. So all patients, remember, at the time of ART initiation and 6 months of ART and every 6 months, some things you must ask. You should ask for a history of whether they've had any heart stroke, heart disease stroke, or developed hypertension or diabetes. If they have any symptoms of angina, breathlessness on lying down, orthopnea, or getting up because of paroxysmal nocturnal dyspnea, or whether they have had loss of weight or increased weight, or thirst, polyuria, polydipsia, any swelling, all these things. Whether they are current or past tobacco users, alcohol consumption, look a bit about their lifestyle and ask for premature heart disease or stroke in their family members or their first degree relatives. Simple assessment, body mass index, weight and height is all that is required to calculate the BMI. And I find that most centers are not calculating BMI of the patients. We should measure their waist circumference. It is a very good indicator of central obesity and the likelihood of CV disc. We must measure blood pressure. I don't know how many centers are doing it, but it is a very simple thing to just measure blood pressure of our patients and look for other features of the NCDs as we shall go back. So we should screen all patients for diabetes, hypertension, and CVD and common cancers. Of course, we can't screen for all cancers. If they are symptomatic, we can then look for a cancer. But screening specifically for cancers only means we can do a pap smear for screening for cervical cancer, or at least we can identify by this people who are at high risk for developing NCDs, which will require further action. And like I said, simple history, basic examination is all that is required, and we shall look about that. Let's start with hypertension. So let us look for the initial screening, diagnosis, and management of adult patients who have hypertension. So what do? All PLHIV or any PLHIV above the age of 18 years should undergo screening by the healthcare professionals through BP measurement. At what time should you do it? We should do it at the time of registration of ART, HIV care or ART. I mean, nowadays there is not much gap between these two. So the first visit or the first two visits, you must screen for blood pressure. Then after ART initiation, every 6 months, the patient must have a blood pressure to be taken. You can also screen these patients if they ask you to check their blood pressure. Sometimes patient will say, doctor, can you check my BP? The 5 days before, when I went to a doctor, I found that my BP was slightly higher. So you can check. Or if you feel that there are some other symptoms patient is developing and you need to check their blood pressure, you can check their blood pressure. So it is not a big deal to check a blood pressure of patients. Patients who are already hypertensive, patients who are already on antihypertensive measurements, on antihypertensive drugs, these patients should have a BP check each time they come in contact with you so that you are able to monitor their treatment. So it is important. BP measurement is not difficult. It is very simple. And this is how you do it. Nowadays, everybody uses a digital sphygmomanometer. We have done away digital meters. We have done away with the stethoscope. So a lot of things are done digitally. There are certain things that one must be careful of, and there are certain rules for checking a blood pressure. The instrument must be kept at heart rate, the back of the patient and the arm must be supported. There is no talking at the time of measurements. The cuff should be at the level of the heart, and you have to use a correct cuff depending upon the arm size of the person whose blood pressure you're trying to check. Patient should have ideally avoided tea or coffee or exercise for at least 30 minutes. But it is very important that they should have rested for at least 5 minutes sitting before you check their blood pressure. And your patient is not encouraged not to speak, and your patient is very relaxed, because each of these errors can give rise to variations in blood pressure, which can vary from as high as 6 to even 10 millimeters. So you may erroneously have a higher reading if all these are not followed, and that is why single readings are usually not relied, and we always insist that 2 readings should be done. Now, it is ideally recommended that on at least 2 measurements taken at least 2 visits, which are 1 to 4 weeks apart, which means you are measuring it using a validated device, using a standard BP measurement procedure on 2 separate occasions. However, you can even use a first measurement as indicative of hypertension if the patient has very high systolic and diastolic values, more than 180 and more than 110, or there is a hypertensive emergency. So these are 2 different things: hypertensive urgency and hypertensive emergency. Emergency meaning, in addition to the raised blood pressure, there is also evidence of end organ or target organ damage. And also, when you diagnose a patient as having hypertension, when the BP is persistently above 140/90. Whenever a patient is diagnosed as hypertensive, you will also simultaneously initiate diagnosis for diabetes, look for renal involvement, and check for proteinuria. You will also try to get a lipid profile done for them, because dyslipidemia is a CV risk factor. You will evaluate kidney function tests, electrolytes, and you should always do an ECG for all patients who have hypertension, because it can demonstrate left ventricular hypertrophy. The target for BP control is that for all patients below 80 years of age, you must try to bring down BP below 140 millimeter mercury systolic and below 90 millimeter mercury diastolic. And for older patients, you can have a slightly higher control, because bringing it down too severely in older people may give rise to a lot of postural hypotension. In addition, all patients require lifelong modifications, including low-fat diet, regular exercise, reduction of weight and maintenance of weight within the target BMI, which is 18.5 to 22.9. And if they are smoking, they need to stop smoking, which is very, very important for all patients who are diagnosed with hypertension. Hypertensive patients may also require pharmacological measurements for the treatment of the hypertension, and this could be either a single drug or it could be a combination of drugs. And like I said, this availability of these drugs depends and varies from state to state, and depends upon the state policies of what drugs are available. You can start with a calcium channel blocker like amlodipine. It is available in most states. Many other states where angiotensin receptor blockers are available, then losartan or even telmisartan is available. You can start with ARBs, or you can also start with angiotensin converting enzyme inhibitors like enalapril, ramipril. So this depends upon what is available within the institution and what is these norms for starting antihypertensive therapy within the district or the state where you are. Many times you may have to combine antihypertensive drugs, because it may not be enough to control it with one drug. So there are grades: grade 1, grade 2, grade 3, and this depends upon the systolic and diastolic management. And the important thing to remember is that as the person progresses from grade 1, grade 2, grade 3, it is usually very difficult to control with single drug or with non-pharmacological measures, and you will usually require multiple drugs, to control blood pressure. It is important that you may need to refer the patients to other centers or other areas within or other facilities. For example, if a patient's blood pressure is not getting controlled with one or two drugs, and the medical officer feels that no, this requires slightly more detailed investigation, then you may need to send the patient to maybe a medicine department or maybe to an NCD clinic, or you may need to refer the patient. It is always important to remember that patients with hypertensive urgencies and emergencies must always be referred to the emergency department for control of blood pressure. This is something that you need to keep it in mind. Let us now come to the other major NCD that we are seeing in large numbers among our PLHIV, and that is diabetes mellitus. So when do you screen for diabetes? Well, it is very simple. You don't have to do anything special. As part of our standard guidelines, at the time of ART initiation, we are anyway doing a blood sugar and we are checking their blood sugars every 6 months as part of the routine care of these patients. So if you're doing that, that itself should help you in identifying patients with diabetes. Otherwise, if you have not screened them till now and would you like to screen them, all PLHIV should undergo screening through random blood glucose. Remember, it is random here, but normally what we are recommending is a fasting blood glucose. And then when do we do that? We do that at beginning or initiation of ART. Then we can do it after 1 to 2 months and then every 6 months. It's part of our guidelines. And whenever you are changing a regimen or you're switching a regimen, or if you feel that you want to request, suppose you detect a patient to be hypertensive, then you may want to examine the patient again and screen for diabetes again. So you're well within your rights to screen again if you feel it is clinically or otherwise indicated. Patients may come to you with very classical symptoms like polyuria, polydipsia, weight loss, polyphagia, weakness, tiredness, excessive candida, generalized pruritus, or multiple urogenital infections. Or they may just come to you because, say, they went for a cataract surgery and they were found to be diabetic. They went for something else and for a pre-screen, they were found to be diabetics. So you can have patients who are either completely asymptomatic or patients may be symptomatic. Either way, diabetes can present with varied presentations. The important thing to remember is you have the diagnostic criteria for diabetes is any patient who has a random plasma glucose of more than equal to 200 along with symptoms, or a fasting plasma glucose of more than equal to 126 milligram per deciliter. Please remember, it is fasting plasma glucose. It is not the glucometer, because with the glucometer, if you're doing a glucometer test in the ART center, you are testing the capillary blood sugar. You're not testing the plasma glucose. So a fasting plasma glucose of more than equal to 126. And very important is glycosylated hemoglobin more than equal to 6.5 is what is defined as diagnostic of diabetes. So random blood sugar, this is what we do in our screening areas, whether it is the OPD area or whether it is the ART center. If you have access to a glucometer, all you need to do is do a random blood sugar. Any patient who has a random blood sugar of more than 140 milligram per deciliter is taken up for further tests. Remember, it is just a screening test. Anybody with a random more than 140 has to be screened further with tests for diabetes, and this is how you do it. And I'm sure most of you have done it or at least have seen it being done. For the diagnosis of diabetes, anybody with a fasting more than equal to 126 or with a postprandial more than equal to 200 or those who have A1C more than 6.5 are diagnosed as having diabetes mellitus. So what else do you need to do? These patients, you need to check fasting and PP depending upon how you are titrating their treatment. The A1C needs to be done every 6 to 12 months, maybe even more if you're changing regimens too fast. Every 3 months, the patient must have a clinical exam. You should always screen them every 6 months for one of the long-term complications like a retinopathy, nephropathy, neuropathy, peripheral vascular disease, and CAD, meaning that all these patients should have a KFT, should have a urine exam. So you need to look for this actively in these patients. You must advise optimizing weight, reducing weight if required, and monitor their waist circumference, also tests their blood sugars and blood pressure. Remember, all diabetics should be screened for hypertension. All hypertensives should be screened for diabetes because there is a very close association between these two NCDs. You must discourage tobacco use and excessive use of alcohol, and you must get a lipid profile, serum creatinine, and urine examination done for all patients who are diagnosed as diabetes. And anyway, most of this is already part of our routine monitoring and routine investigations that we do for our patients on ART. So this is nothing excess that we are doing, but you must make sure that this gets done. There may be multiple referrals that you may need to be provided for these patients, and initiation of oral hypoglycemic agents shall be done by the physicians, and the medical officer should know how to manage diabetes. Cardiovascular risk factor screening, assessment, and initiation. These are some of the important cardiovascular risk factors: hypertension, diabetes, dyslipidemia, especially total cholesterol, LDL, or high triglycerides. In fact, we find that a lot of our patients have excessive triglycerides, high LDL. Sometimes these are very, very important to see. Many of our patients have obesity and increased waist circumference. Physical inactivity, tobacco use, alcohol, poor diets, and family history. These are all important cardiovascular risk factors. Let us now go and see what are the important anthropometric measurements that we need to do at the ART center. The first and the simplest thing that should be done and must be done in all our patients is calculating the body mass index or the BMI. The BMI is a very simple tool. It's a screening tool for estimating the total body fat content in the body. It is calculated by dividing the weight in kgs upon the height in meter square. So you need to have, you already have weighing machines in the ART centers because you're anyway weighing the patients every visit. You should also have a stadiometer or a non-stretchable tape that can measure the patient's height. The height need not be measured every time. The height can be measured only once for adults because height does not change unless it's a very small child where growth is happening. For an adult, once adult height is reached, height does not change. So you just need to measure the height once on the white card. But weight you have to measure and calculate with the most recent weight. So BMI is calculated using this formula. You can do it with your hand, but nowadays even apps are available on the mobile phones, which I'm sure many of you have downloaded. And there are even some machines where you can do the height, weight, and BMI calculations together and you get the values. It is an invaluable tool for all patients, whether you are trying to look for undernutrition or whether you are looking for obesity. BMI is a very, very important tool or anthropometric measure that we need to use very frequently in our ART center. Obesity BMI is categorized according to ICMR guidelines into the following categories. Anybody with a BMI less than 18.5 is categorized as underweight or poor nutrition. Normal BMI is between those who have a BMI between 18.5 and 22.9. This is something that you must remember by heart by now. Overweight are those who have a BMI between 23 and 25. And anybody with a BMI more than equal to 25 kg per meter square are classified as obese. These are ICMR guidelines. For waist circumference more than 90 or higher for men and 80 or more for women is categorized as central obesity as far as Indian guidelines are concerned. We all talk about CAD, we all talk about hypertension, we all talk about blood pressure and kidney disease. But some of the things that are less talked about are mental health. This is one of the less explored areas in our ART centers, and we tend to not assess patients for mental health issues when we know that a lot of these patients have stress, anxiety, depression, may even have more severe forms of mental health. And this is something that we need to be aware of and we need to assess for and manage among our PLHIV. And we'll talk very briefly about mental health among our PLHIV. We know that PLHIV are prone to psychological ailments either due to the HIV illness per se as well as because of the opinions and experiences regarding HIV in their surroundings. This could be because of interactions with society, with family, with communities, with partners, with general population. So people living with HIV face a lot of psychological issues. They also face multiple stigma which they could have internalized, and that can give rise to multiple psychological issues like depression, like anxiety, like panic, all these kind of issues, and some of them are very, very troubling for these patients. Any psychological issue can significantly hamper adherence, and we know that the presence of psychological abnormalities is one of the most important keys and deterrents or barriers to good adherence among PLHIV. Mental well being also gets severely compromised, and their quality of life is also compromised. It is well recognized that depression is 2 to 3 times more prevalent in PLHIV than the general population because of multiple reasons. And we need to be aware of this fact when we are managing our patients. So, how do you screen for mental health in our patients? So, it is very simple to screen for depression. It is not difficult. There are only two questions. It's a very simple questionnaire called PHQ-2. Every PLHIV should receive basic screening for depression before initiating ART and every 6 months using the following two questions. During the past 2 weeks, have you often been bothered by feeling down, depressed, or hopeless? And during the past 2 weeks, have you often been bothered by little interest or pleasure in doing things? These are two screening questions which will help you maybe identify possible suspects with mental health. And if any of these questions is answered as yes by the patient or the client, then these patients should undergo more extensive investigation using other screening tools like the PHQ-9 for identification of depression. So these are very simple two questions that can be asked by the counselor at every 6 months and see whether or not patient in the last few weeks has been troubled by depression. This is the PHQ-9 or the Patient Health Questionnaire 9. This is to be administered, or you can administer other health questionnaires. There is the HIV depression scale. There are multiple scales that can be used, but this is something simpler which has been used in multiple settings. And so this can be done only to those who answer positive to any of those prior two questions. And you can score them. Depending on their score, you can identify those who have mild depression or who are having more severe forms of depression. There are key supportive counseling that need to be delivered to these patients. One of the most important is psychosocial support. You have to explain, and these are important key areas where our counselors have a role. They can explain about depression, that it can be managed. You can counsel them about treatment, identify supportive family members, involve peer and community support groups. You can engage in self-management skills, help them get regular and sufficient sleep, increase physical activities, find measures or techniques or strategies that will reduce stress. For that, you need to, but for all these things, you need to spend a little time with your patients and then identify which are the key stressors or the key areas which are troubling the patients most, and whether or not the ART center can provide some kind of succor for these areas. But remember, many times you may require and you will require reference to a psychiatrist or an other expert counselor for management of depression in these patients, and you must facilitate that. So you can try antidepressants, but that should only be prescribed by a psychiatrist. That is why I said you may need to refer the patient to a psychiatrist, and there are procedures for starting it, stopping it, and you need to know what type of ones are usually being used. In children also, mental health is a big issue, especially it's seen among adolescents. They have difficulty in school, they have social skills are impaired, they may have behavioral abnormalities, they may become aggressive, they may become very quiet, or there is a difficulty in regulation of emotions. And it is very, very well known that anywhere between 8 to 13% of children, especially adolescents with HIV, need to be referred to mental health services. So if you if you look at your patient and you identify any of these things, persistent sadness, withdrawal, anybody talking about hurting oneself, outbursts, emotional irritability, out of control behavior, drastic mood changes, eating very less, loss of weight, difficulty in sleeping, many other problems like stomachache, headaches, which have no organic causes, difficulty in concentrating, poor scholastic performance, patients are not going to school or avoiding school. If you notice any of these things, then your child or the adolescent may be suffering from a mental health disorder that needs to be evaluated. So you can, so now comes what do you do after diagnosis and management of any of the NCDs? So PLHIV who have screened positive for an NCD shall be referred to an NCD clinic. Now, there are NCD clinics that are established under the National Program for Non-Communicable Diseases. These are present in district hospitals. These are also present in higher health facilities where the PLHIV can further undergo diagnosis and treatment. In the district hospitals, they can go to the NCD clinic. But if your ART center is in a medical college, you actually can manage it either in your own ART center or you can refer to an appropriate specialty department within the institution so that they can be integrated with care. For mental disorders, there is something which is known as a National Mental Health Program. And so all district hospitals have a component of the National Mental Health Program. And there are other medical colleges also have psychiatry departments and other agencies which can look after mental health disorders. You need to document all these. You should document the screening, document the referral, details of these are the things, these are the areas in the white card where you should follow in patient section 13. Comorbidity should be documented in section 9. And also in the IMS, you should be able to document comorbidities and NCDs. Otherwise, if we do not document and record the NCDs, the program will never get an idea as to what is the extent of the problem. Unless you screen for it and unless you document it, I am sure many of your patients are taking treatment for diabetes and hypertension, but it is never documented anywhere. So if I ask you on a personal level, you will say, oh, madam, so many of our patients are diabetics. But if you look at the data and if you look at documentation, there will be very limited number of patients who have been documented within the existing documentary framework. So we need to write it down. We need to document all these details in the IMS. So you need to have certain health promotion activities given to all PLHIV. These will promote healthy life. Within that, you will screen for early detection of diabetes, hypertension, CAD, and anybody who has this will be referred for further diagnosis and management. And this is kind of a continuum which is happening in these patients. So let us look at some health promotive behaviors that we can improve in our patients. It will include physical activity, active physical, moderate physical activity of at least 150 minutes per week or for 5 to 7 days a week for 30 minutes each. Yoga, meditation, many people find it is very helpful. Weight control is very, very, very critical. You need to maintain the BMI within the normal range for the PLHIV, especially those who are hypertensive, diabetics, CAD. It is very important for them to lose weight through a combination of exercise, diet, and other measures. Patients should be encouraged to take balanced diet with nuts and wheats and vegetables and pulses and fruits. Very important to reduce salt. All of us tend to eat much more salt in our diets. So the less the salt, the better it is. Less the amount of fat, the better it is. Less the amount of sugar that is consumed, the better it is. Tobacco cessation is very important across life. If a person is using tobacco in any form, chewing, eating, smoking, we need to cut down on tobacco. Alcohol also, high doses or high consumption of alcohol needs to be cut down, and very, very, even if patient actually ideally it should be avoided as far as possible. And of course, if a patient is diagnosed to have NCD, the person needs to take the drug for the NCD. And also the MO at the ART center should know what are the important drug-drug interactions that can happen between drugs used for NCDs and the antiretroviral treatment drugs. The role of the different cadres of people within the ART center is the role of the staff nurse is to assess the MO during the examination in follow-up of care, and of course BP screening. It is very important that recording of BP must be done by the staff nurse, and they should know how to record blood pressure. They should also be helping in recording the height, weight, hip circumference, and waist circumference. Remember, the height needs to be recorded only once, and weight is recorded every visit. These needs to be done only once in 6 months. There should be a recording in the survey forms, and all the explanations has to be done. The counselor screens for the 2 questions for the PHQ basic screening, and those who have a positive PHQ may be then screened in more detail and spend some time. Look for family history, past history, counsel the patients, assess depression, counsel on diet, counsel on lifestyle management, counsel on positive living. All these are important roles. History taking, physical examination has to be done by the medical officer. Look at the investigations, interpret the investigations. Start preliminary treatment, plan referrals, decide where the patient has to be referral, and make recordings in the white card. These are important roles of the medical officer. Referrals for investigations, admissions, consultations, all these are the role of the medical officer after examining the patient. Remember, the ART, SMO or MO either can start the treatment at the NCDs at the ART itself. If a patient has diabetes, it is simple to start metformin. You can add glimepiride or any other sulfonylurea depending upon the availability in your institution. For hypertension, the MO can start either amlodipine or ramipril or telmisartan, again, depending upon institutional availability, choice, and program availability. Or else, it can be referred to the medicine department of the same institution or the NCD clinic or a nearby dispensary district hospital, whichever manages an NCD. Follow up if the patient has reached the referral center. It is not just enough to tell him or her to go there. At the next visit, find out, did the patient go to the referred center? What was done there? What was prescribed? What drugs the patient is taking? Because we know that metformin dose has to be modified. So these are things, drug-drug interactions may be there. So these are things that the ART-MO should look up when you are referring patients. There are certain challenges. It is not that everything is very simple and it is very simple to integrate the care. There are challenges. Some investigations may not be available. For example, you may need a further investigation, and the PLHIV may need to visit a higher center. Maybe the patient's ECG had some abnormality and a cardiology consultation was required. So that may not be available in the hospital. A higher center referral may be required. The patient may have to visit another facility for management. Suppose the patient has CKD or the patient has nephropathy. You may desire a nephrology consultation or some other specific workup that may require the patient to go somewhere else. And also, the patterns of prescription of drugs varies from state to state, like I said. And so those are challenges. We cannot say that all ART centers should start amlodipine 5 milligrams. It may not be available in your center, right? So these are things that are challenges. And of course, complications will always need specialist management that cannot be done at the ART center, and the patient may need to visit other facilities. So what is happening is we are trying to reduce the multiple facilities or multiple areas with the PLHIV has to visit, and trying to provide comprehensive care within one facility or one center. It is possible to a certain extent, and that is what we need to facilitate. So in conclusion, I'm going to conclude by saying that NCDs are common among our PLHIV, and they are the leading causes of morbidity and mortality among PLHIV now that we have been able to control the OIs to a very large extent. With the aging population of PLHIV, the NCDs are going to play a dominant role in the management of PLHIVs, and we need to know well how to manage them. Screening for NCDs is very simple. We need to measure a blood pressure. We need to do a random blood sugar or a fasting sugar. We need to measure a BMI. We need to look at the lipids. That's all that you need to do to diagnose NCDs. And even the initial management of NCDs is possible within the realm of the ART center. And integration of NCD and HIV care is very critical to achieve a holistic approach to the management of people living with HIV. Thank you very much for your patient hearing. I think we will have the post-test now.
Yes, ma'am. We'll just take up questions first, ma'am, and then go for the post-test.
Perfect.
Right?
Perfect.
Yeah. Kiran sir, we can give mic access to everyone. In case anybody has any questions, please feel free to put them in the chat box, or you can also unmute. Any questions from the participants?
I don't see any questions in the chat box.
No, there are no questions in the chat box, ma'am.
Yes.
Participants can unmute their mic in case they have any questions.
Excuse me, madam.
Yes, sir.
One question. In some cases of cancer, before chemotherapy, many patients are telling that their cancer doctors are advising to stop ART for temporary periods. Is it necessary actually?
No, no, doctor, no, that is not correct. The patient should continue on antiretroviral treatment even throughout the period of starting chemotherapy. In fact, you will find that the many patients who are receiving chemotherapy or other treatments will actually ask you to get an additional viral load to see whether they are virologically suppressed or not. So no, there is no point of stopping the ART, not at all.
My next question is, madam, is CD4 count necessary before chemotherapy?
It is better to get a viral load rather than a CD4 because many times interpretation of CD4 becomes very difficult, especially if you're dealing with hematological malignancies. If a patient has a hematological malignancy, the marrow may be suppressed anyways, and you may already have a CD4 count which is very low. And so analyzing and interpreting that is going to be very difficult. And anyway, as far as our management goes, it is more important to see if the patient is virologically suppressed or not. So it is better to get a viral load done to see whether patient is virologically suppressed or not.
Okay, thank you, madam.
Ma'am, there's a question in the chat box.
Yes.
Any time
Should be taken between antihypertensive diabetic medication? No. They can be taken at the same time. No, there is no need to have a gap between them. No.
Any more questions? Please feel free to put them in the chat box, or you can also unmute your mic and ask the question.
Okay.
Ma'am, we'll go ahead with the post test.
All right.
Kiran sir, can we have the post test, please? Thank you. The post-test questions are now visible on your screen. These are the same questions from the pre-test. Please scroll through all the 3 questions and answer them. The first question is, which of the following is not a risk factor for cardiovascular disease and PLHIV? Options are smokeless tobacco chewing, total cholesterol less than 200, body mass index is equal to 22.8 kg, aging process, triglycerides more than 150 mg. Which of the following is not a criteria for diagnosing diabetes in PLHIV? The options are symptoms of diabetes or random plasma glucose more than or equal to 180 mg, fasting plasma glucose more than or equal to 126 mg, 2-hour post 75 gram glucose more than or equal to 200 mg, and glycated hemoglobin more than or equal to 6.5%. Which of the following is or are warning signs for indicating presence of a mental health condition in children and adolescents? The options are weight gain, changes in academic performance, self-harm, changes in eating habits. Requesting all the participants to please answer the e-poll. Meanwhile, participants can unmute and ask questions if there are any questions. We'll keep the e-poll for another minute. Ma'am, please allow me to share my screen.
Yes. You want me to
Yeah,
share the screen?
you can stop sharing, ma'am.
Okay, I'll just do that.
Thank you, ma'am. We shall quickly display the correct answers. The first question, which of the following is not a risk factor for cardiovascular disease in PLHIV? The correct answers are total cholesterol less than 200 and body mass index is equal to 22.8 kg. These are not the risk factors for cardiovascular disease in PLHIV. Which of the following is not a criteria for diagnosing diabetes in PLHIV? The answer is symptoms of diabetes or random plasma glucose more than or equal to 180 mg. Which of the following are warning signs of indicating presence of a mental health condition in children and adolescents? The answer is changes in academic performance, self-harm, and changes in eating habits. Thank you so much, ma'am, for facilitating this session.
Madam,
Yeah, please go ahead, sir. So you have a question?
oh,
Yes, sir, we can hear you.
madam, in one of my patients who was suffering from multiple arthritis, his treating doctor has prescribed steroid therapy, though it was to be tapered in the after certain period. Is it actually necessary in that case, because it is just acting opposite to our ART?
All right. So, doctor, I get this question very frequently as to whether steroids can be prescribed to PLHIV because they have some immunosuppressive action, correct? Is that the question?
Right, madam.
So, doctor, if it is clinically indicated for any other condition where steroid needs to be given, a short course of steroids or even a slightly longer course of steroids will not do more harm as long as your patient is on ART and the patient is virologically suppressed. So, yes, if there is a life-threatening situation, like for example, patient has severe uveitis and needs to be given steroids, you will prescribe the steroids, no, because you don't want the patient to lose life or limb. So steroids, if they are clinically indicated, can definitely be given even in patients with HIV, though we must understand that it has to be, it can contribute to more immune suppression, especially in those who are not virologically suppressed.
Right. Thank you.
Welcome.
Any more questions? Dr. Vinoda, ma'am, would you like to ask any question? Oh, ma'am, I don't think there are any more questions.
Yes.
Thank you so much for facilitating such an important session.
Thank you so much, Shweta. Thank you, everybody, for a very nice and pleasant hearing. Thank you.
Thank you to all the participants for patiently listening. We'll soon be sharing the session PPT as well as the recorded link with all the ART centers. In case you don't get the email, please reach out to us. Thank you, everyone. We'll conclude the session now.
Good afternoon.